everybody to Ask the Experts, a conversation hosted by SCAD Alliance. I'm Rebecca Freeman. I'll be moderating and leading the conversation today. I'm a board member of SCAD Alliance and two-time SCAD survivor. So if you're new to SCAD Alliance, we are a nonprofit organization founded by survivors in partnership with leading cardiologists and health advocates to advance the science of SCAD. One of our main projects is an independent multi-center iSCAD registry. And another of our large goals is to support patients and families. And so as part of that, we've developed this monthly webinar series, Ask the Experts, and we hope to offer support and education to survivors and caregivers by engaging in conversation with experts on SCAD-related topics each month. So be sure to check out our past webinars on everything from genetics to PTSD, exercise, emergency room care. They're all on our social media channels. So today we're talking about clinical studies and research. During our advocacy webinar last fall, we talked about research in terms of individually gaining knowledge of SCAD, but today we're talking about research in terms of clinical studies and gaining knowledge of SCAD as a scientific community. So we're survivors too. We know how right after diagnosis, it can feel like maybe there's no information to be found, and we see confusion online about research and a perceived lack of it. And this webinar was designed to address this. So much has been learned about SCAD in recent years, and there's so many amazing clinicians doing this work. So today we're going to discuss where we stand with SCAD, why it's important to participate in clinical trials, and if you do, why it's important to commit long-term to that participation. So with that, I'm going to introduce our panelists. I'm going to read a little bit more of a bio than I usually do because I think it really highlights the dedication of these physicians to both clinical care and long-term understanding for us as SCAD patients. So Dr. Gretchen Wells, I'm going to wave, thank you, is Director of Women's Heart Health Program at University of Kentucky Gill Heart and Vascular Institute. In addition to SCAD, her research focuses on the connection between psychological attributes and cardiovascular disease outcomes. She also studies novel approaches or new approaches to microvascular disease. And Dr. Wells participates on the national level in the Women's Health Initiative, WHI, an NHLBI funded study that began in 1991 and has identified a number of advances in women's healthcare. Dr. Wells is the principal investigator of the iSCAD registry site at University of Kentucky. So I have Dr. Heather Gornik. Dr. Gornik is co-director of the Vascular Center at the Harrington Heart and Vascular Institute at University Hospitals, as well as the acting chief quality officer. She is an internationally recognized expert in the care of complex vascular diseases, particularly fibromuscular dysplasia, and serves on the medical advisory board of FMDSA and the steering committee of the United States Registry for FMD. She led the development of national guidelines related to the diagnosis and clinical care pathways for patients with vascular disease and is an expert in non-invasive vascular diagnostic testing. Dr. Gornik is also the principal investigator of the iSCAD registry site at University Hospitals. And Dr. Esther Kim. Dr. Kim is director of the Arteriopathy Clinic at Vanderbilt Heart and Vascular Institute. She specializes in uncommon arterial disorders, including SCAD, FMD, aneurysmal disease. Dr. Kim holds leadership positions in several national cardiovascular societies, including the Society for Vascular Medicine, the American Society of Echocardiography, and the American Heart Association. And she currently serves as the associate editor for Vascular Medicine, which is a premier peer-reviewed vascular medicine journal. Dr. Kim's the SCAD Alliance Scientific Advisory Board Chair and the National Principal Investigator of the iSCAD Registry and iSCAD Steering Committee Chair. So we're in for an amazing discussion today. These webinars are such a reassuring reminder for me as a patient that we have really great researchers on our team. So without further ado, I'm going to turn it over to them, and Dr. Wells is going to start us off with a discussion of the state of women's heart research.
Thank you for that kind introduction, Rebecca. Let's make sure, is my screen shared now? Okay, how is that?
There we go.
Okay, perfect. Thank you all. Okay, so we're going to spend just about 5 minutes talking about researching cardiovascular disease in women. So let's get to the next slide. Okay, one of the earliest studies that most people in cardiology know about is the CAS study, the coronary artery surgery study. And this was an important trial because it identified that for patients who had severe obstructive disease in the left main artery or 3-vessel disease and so on, that these patients actually did better with surgery than with medical therapy. But there's a catch to some of the other papers that they published as a result of that trial.
Dr.
And
Wells, I'm going to interrupt
yes.
you real quick. I'm so sorry, but I don't think your slide advanced. We're still seeing your introduction slide.
Oh my goodness. Okay. How is that?
There we go. That shows the paper.
Okay, good. So that shows the paper here.
Wonderful.
Well,
Thank you.
okay, no, thank you for letting me know about that. So what is important about this particular paper is that this clinical trial, unlike many others, actually enrolled both men and women. But they concluded in looking at the women, when they enrolled the people with angina in this study, that they did not have obstructive coronary disease, that the cause of their chest pain was not due to coronary disease, but to something else. It was not cardiac chest pain. And so people believed this for a number of years, that women actually did not get heart disease. But the statistics don't lie. And did my slides advance here? This should show a graph. Okay, good. Okay, so this is something that many of you may have seen regarding cardiovascular mortality in men versus women. What you're seeing on the bottom are over the years, and what you're seeing on the what we call the y-axis going vertical are the number of deaths. And in blue are the men, and in red are the women. Well, there were a number of clinical trials that addressed heart disease, and these trials mostly focused on men. Again, we were convinced that men did not have significant, or correction, that women did not have significant cardiac disease at that time. But looking at the data, it told a different story. You see in red that while what you're seeing here is that the survival in women was actually getting worse, while the survival in men was improving. Now, this got the attention of Bernadine Healy. Dr. Healy is shown on the bottom left. She got around. She was head of the Red Cross at one time, the NIH at one time, and she published an editorial in one of our leading journals, the New England Journal of Medicine, which incidentally published a SCAD article that Dr. Kim wrote at the end of December that was terrific. So I would refer you all to that. But going back to 1991, Dr. Healy published an editorial where she questioned maybe the heart disease women get is different from what men get. And she entitled this the Yentl syndrome. And I never saw this movie, but Yentl was played by Barbara Streisand, shown at the bottom right, where she wanted to be a rabbi. But in order to be a rabbi, she had to dress up like a man. And Dr. Healy's point was, in order for women to be recognized with their heart disease, they had to be their heart disease had to be identified as that similar to a man. So she launched the Women's Health Initiative, which was whose purpose was to explore the differences between men and women. With some of that leftover money, it went to fund the Women's Ischemia Syndrome Evaluation, or WISE. And this study proved her point. What they found is over 50% of women who had a strong clinical indication to undergo a cardiac catheterization did not have obstructive coronary disease, meaning they had abnormal stress tests, they were having classic symptoms for angina. You do a cardiac catheterization on them, there was nothing obstructive. Many of these women were erroneously told this was a false positive stress test, meaning the stress test was wrong. But then they later studied these women and found out, no, that's not the case. They had some newer techniques that were developed, and they were able to measure a particular test called the coronary flow reserve and found that that was abnormal. So in fact, about half of these women actually had microvascular disease. It turns out the prognosis was not benign. And we really don't need to tell this crowd that the type of heart disease that women get often is different from the type of heart disease that men get. And another example, Dr. Lindenfeld, I believe, is at Vanderbilt now, isn't she? Dr. Kim, yeah. She published this article when she was in Colorado in the Journal of the American College of Cardiology. Where are all the women with heart failure? We had so many clinical trials of men with heart failure, but the women weren't included in those trials. It turns out that no one was discriminating against the women. The type of heart failure that women got was different from what men got. The men with heart failure oftentimes had a very dilated, weak heart muscle, but the women had a preserved ejection fraction, meaning their heart was squeezing perfectly fine, but there were other problems to explain the heart failure. And we've paid a price for that difference. There are a number of treatments for systolic heart failure. And this is just a partial list of the medications that are approved by the FDA for systolic heart failure. But with a diastolic heart failure, what we now call heart failure with preserved ejection fraction, this is a complete list of the FDA approved medications, which you think, well, there's nothing on there. That's right. There are no FDA approved medications yet for heart failure with preserved ejection fraction. So clearly more research is needed. So when we talk about research, medical research, we put that into several buckets. There's the basic science research, which is what many of us have done, and certainly what I did at the beginning of my career, which involved looking at, I was in the lab, we used test tubes, we had chemical reagents and so on, but we weren't around patients. Sometimes we did some animal studies. Clinical research is different, and there are many types of clinical research. This can involve things like registries, of which iSCAD is one, randomized control trials, where many of you have heard about those in recent months with the different vaccine trials and so on. But what we know about clinical research is that it is very well organized. All participants in clinical research are protected. If any of us wants to do a clinical research study, we must secure approval from an institutional review board. These were set up years ago in order to protect patients. And we have to prove to this outside board how we are going to protect patients, not only from harm from the study itself, but also patient privacy and so on. And in order for a patient to participate in research, it must be voluntary, and they must review a consent and have a number where they can reach anyone involved in, or reach the investigator involved in the trial if there are any questions at all. Most good studies, for example, in iSCAD, the outcomes are adjudicated, meaning we have expert reviewers look at the studies. That is why the angiograms that are sent by iSCAD are reviewed by a central site to determine, is this really a spontaneous dissection? Could this be something else? And so on. So that is really about what I wanted to say about how we do medical research in 5 minutes or less. And if at the end of the webinar, if there are any questions, or if you want to email me or so on, I'm happy to answer those. So thank you very much, not only for allowing me to present this, but to be included in this group.
Absolutely.
Absolutely.
Thank you so much, Dr. Wells.
Okay.
Dr. Wells. I'm echoing. Not sure. There we go. So wanted to say thank you for that. I think that's a really good background, and it gives us a really good understanding of, you know, the fact that women haven't necessarily been included in this research and how that's changing. We've talked, you know, a lot on and off about iSCAD, and so Dr. Kim, can you please take us next to, you know, specifics about iSCAD? What is this registry that we're hosting, and how people can be involved?
Thank you, Rebecca, and thank you, SCAD Alliance, for putting this together today. I'm really excited to share with you about the iSCAD registry, and I'm very excited to share this webinar with Dr. Wells and Dr. Gornik. So I'm going to start right off and define what a registry is. I took this definition from the Agency for Healthcare Research and Quality. And a registry is really an organized system that uses observational study methods. And that means that we're not actually testing a drug or a test. We are observing what happens to patients in the course of clinical care to evaluate specified outcomes for a population defined by a particular disease. Meaning that when we start a registry, we have specific questions that we want to answer. So in regards to SCAD, that could be, what are the rates of recurrence? What is the prevalence of fibromuscular dysplasia if you have SCAD? So any good research study starts with a good question, and the research study is developed to help answer the question. And obviously, the population defined by the particular disease in this case is patients who have spontaneous coronary artery dissection. And the purpose for this registry is to serve a predetermined scientific, clinical, or policy purpose. So in brief, a patient registry is a collection of standardized information about a group of patients who share a condition or experience. And I think that word standardized is really important because the way we gather the information helps us to process it so we can analyze it together. So for instance, if we were studying about family history, you could ask an open-ended question like, do any diseases run in your family? And then have a patient answer with all the potential diseases that run in their family. The other way to do it is to have a hypothesis that perhaps connective tissue disease runs along with fibromuscular dysplasia. Then you would ask very pointed questions. Does anyone in your family have double jointedness? Does anyone in your family have funny looking scars after a surgery? And so that's what that means about standardized information, is that we know exactly what variables we are going to collect so that we can answer our question most efficiently. I really liked this figure that I got from shareforrare.org, and I think this describes what we're trying to do as a patient registry very well. So there are really two ways that data can enter into the registry. One is that patients or their family members directly enter data into the repository, and doctors enter clinical data into the repository. And in the repository, which for us is the centralized coordinating center called Perfuse, the data meet each other. And so we can tie together patient questions and the clinical data that the doctors have. And so some of the examples of data that patients may enter could be details about your medications, about your symptoms, when you were diagnosed, about your quality of life. So for instance, in iSCAD, we ask things about anxiety, depression. We ask you about your obstetric history and your other medical history and your family history. And then the data that the doctors may enter could include things such as a clinical description. So did this patient have a CAT scan? And if they did the CAT scan show any abnormalities of the carotid arteries, or did it show any aneurysms of the brain? And so those two types of information are gathered from different sources, but they meet each other in the centralized data repository. And then once the data meet each other, then we can perform analyses. Once we have a critical number of patients who were followed for a sufficient amount of time, that we can actually make some conclusions about the data. And that information can actually develop into more research. So let's say through the registry, we discover that there is, let's say just for fun, that 80% of patients with SCAD answer that they have sleep apnea. And no one's ever really thought about that before, but that's a question that one of the patients actually had about SCAD and heart attacks. And so let's say we discover that SCAD is related to sleep apnea. that could lead to further research about how do we further study sleep patterns or breathing patterns in patients. Certainly, it can develop into standards of care. As you may know, the American Heart Association published a consensus on the care of patients with coronary dissection. And really, we could make some recommendations based on the consensus of expert opinions, but it's really research that's going to drive firm recommendations so that we can say all patients should have this particular testing or all patients should be on this type of medication if they can. And then certainly for a rare disease like SCAD, where we're just starting to do the research, the dream would be to actually develop clinical trials where we're actually testing treatments and medications that could potentially prevent a recurrence. So what I mean by that is currently, many doctors will say beta blockers may be beneficial. It's been shown in one study to maybe perhaps prevent, that's my dog, I'm sorry. It could prevent another SCAD from happening. But the real way to test a hypothesis like that would be to take 100 patients, randomize them, half of them get beta blockers and half of them don't, and then follow them out to see what are the rates of recurrence. So as you can see, we're sort of at the beginnings of SCAD research, and really this will be the gold standard for helping us develop treatments. Well, when we're talking about SCAD, it is a rare disease. We know that it's not very common. So, it took a long time for some of my own patients to meet another patient who had SCAD. And thank goodness for Facebook and social media, because now patients can meet each other all across the country. But it's difficult to do research when you don't have patients who are clustered geographically. Because it's difficult to bring them into one area to get them a scan or to collect information. The other barrier is that expertise is really limited to few experts who are dotted sort of across the country. And so patients have to travel long distances, perhaps to get the care that they desire. And then finally, research costs money, and the traditional means of funding could be hard to come by. For instance, because it's a rare disease, a drug company may not want to invest billions of dollars on a medicine to treat just a few thousand people. And so we really have to get creative about the research that we need to do to advance the science in rare disease. So in terms of iSCAD, some of the things that we have thought of to try to make the study as pure as possible and as easy as possible to advance the science as quickly as possible are shown in the study design. Number one, it's multi-center. The data is not housed at one center. There are multiple centers, 16 around the country, who are asking patients to be a part of the center or a part of the study. And that information is going to be shared in that central data repository. We're allowing patients who have had a SCAD several years ago, as well as patients who have been recently been diagnosed, to be a part of this study, because we think we can learn from the patients who had their SCAD 10 years ago to understand their rates of recurrence and the medications they've been on, and we can learn from them. But we can also learn from the patients who just had their SCAD in terms of their chest pain symptoms, their anxiety, their depression, and sort of their journey as they get to healing. And so this is really a longitudinal study. We don't look just at one point in time when patients are hospitalized. We send recurrent questionnaires so we can figure out what happens to anxiety over time, what happens to chest pain over time. And then finally, it's an observational study. We are not testing a drug. We're not testing a diagnostic test. We really want to see what happens to patients. We want to know the natural history. As Dr. Wells mentioned, one of the very important things for us is core lab adjudication of coronary angiograms, i.e., we want to make sure that everybody who is entered into iSCAD has a definitive diagnosis of coronary dissection. We don't want to muddy the waters with diagnoses that are not SCAD. Clinical data is compiled by medical staff, and then historical psychosocial data is entered by the patients themselves in an online survey that is emailed to them periodically, depending on when they had their SCAD event. This is the organizational structure of iSCAD. And you can see here that we've got data entering into the coordinating center Perfuse in two different ways. We've got the registry centers with the doctor sending in clinical information, and then this is the role of the patients. Almost half of the data in iSCAD comes from the patient questionnaires. And so if you are a part of this registry, it's really important to try to answer all the questions to the best of your ability, and to also answer every survey that you get from the coordinating center. Because if you don't answer that, we're missing half the data. And one of the things that is so special and unique about iSCAD is that the patients help to develop this study. And so it's really developed to be for patients. And so if you are in this, please turn in your questionnaires. Our funding is from SCAD Alliance, and SCAD Alliance does a lot of work to raise money on special occasions. And I know patients directly also, you do birthday fundraisers on Facebook, know that that money is going to good use and it's supporting the work of the registry. So when the data enters into Perfuse, the coordinating center, it becomes iSCAD data and it gets analyzed, and then it goes through a publications committee, which decides what are the most important questions that need to be answered first. And in what way should this be analyzed? And then we submit this to medical journals so that it can be dispersed as information for doctors around the world and also patients. The coordinating center, Perfuse, is run by Dr. Mike Gibson, who has been doing this for a very long time. If you don't follow him on Twitter, I would encourage you to do so. He's quite the Renaissance man and extraordinary cardiologist who has so much experience running studies. We're very fortunate to have him sort of lead the helm at Perfuse and helping us manage all of this very important data. I wanted to show you the currently enrolling sites. We're very proud of the fact that we are now officially coast to coast. We've got sites in California and all the way over to Massachusetts. Eventually, we're going to be north to south. We're going to get the Dakotas in there, and we've already got Texas in there. But would love to get a Florida site too. So we are trying our best to make the study accessible to patients around the country. The study's timeline is a very busy slide, but I put this up here to show that the frequency at which you get a questionnaire really depends on when you are entered into the study. So if you've had a SCAD more than a year ago, really you're only going to get one questionnaire a year, and hopefully that is not overly burdensome. A lot of things happen. I know a lot of my patients will attest. A lot of things happen during that first year that you have your SCAD. There is chest pain. There are feelings of anxiety, depression, PTSD. There's a lot of medication adjustment. There's a lot of testing going on. For that reason, we do have several points during that first year where we ask you to complete surveys so we can record your SCAD journey to healing. I'm really excited to show you this slide and to really show you really sort of the exponential growth of this registry. Patient number 1 was enrolled in March of 2019. And as of this month, we have 549 patients enrolled. And that's really speaks to the dedication of the enrolling sites and the doctors, but also to patients who are so excited to participate in this research. So thank you. Well, what makes iSCAD special? There are lots of registries out there, and I do encourage participation in as many as you want. But I think what makes iSCAD special is that it's a patient-run registry. It's funded by patients through the patient organization. Patients have put in questions that they want answered. And so questions in iSCAD were developed specifically to answer the questions that patients were interested in. Patients obviously are participating in the study. And once the study results come out, patients will have a key role disseminating the information from the registry. You're the ones that frequently teach the doctors. I just had a patient of mine teach me that COVID patients can sometimes have positive ANAs. I didn't know that in the past. She shared a New York Times article with me. So I learn as much from my patients as they do from me sometimes. And so really you're a very important piece of disseminating information about coronary dissection. I also think that having a centralized, experienced coordinating center and a core lab for angiograms is very important because there is massive amount of data that we're collecting. And so to have the experience of Dr. Gibson's team to be able to organize all of that data and then to analyze it using verified statistical methods is so important. And also to read the angiograms and verify that every patient in iSCAD does indeed have SCAD. iSCAD is also special because the providers are dedicated. This study, we don't pay doctors money to enroll patients. And so this really comes because the doctors are so dedicated to advancing the science and to helping patients. So they take the time out of their day without compensation to really fill out these forms, to send the angiograms in, to participate in webinars such as this. Thank you, Dr. Wells and Dr. Gornik, and participate in many other educational programs. And iSCAD is also special because we're multidisciplinary. We have radiologists, women's heart cardiologists, we have vascular medicine specialists, we have interventional cardiologists, we have women who are interested in the pregnancy period, who are cardiologists involved. So there are many, many different specialties and many, many doctors around the country who are contributing to this research. So I wanted to end by showing you that the iSCAD registry, the first thing that we did before we even came up with the study design was put down on paper what our mission and our vision is. And our mission really is, as you can see at the end there, we want to improve patient diagnosis and outcomes and accelerate scientific discovery. And we always hold to these mission and vision statements as we think about why we're doing this. And with every step we take, we say, does it stick to the mission and the vision? And that's all I have. Thank you very much.
Awesome. Thank you so much, Dr. Kim. This registry is something we've been really, really excited about. And it's always neat to see the numbers and that we have over 500 patients enrolled. It's just really, really exciting. And when I turn over to Dr. Gornik, so the idea of a registry is not a brand new concept. And I know you're pretty involved with the FMD registry, so I'm hoping you can talk about research and registries and what we've learned.
Thank you very much, Rebecca. And can you confirm my slides are okay?
Yep, looks great.
Okay, thank you. Actually, I may be, sorry, I'm having a little technical glitch. Give me 1 second. Okay, how's that? Good?
Perfect.
Okay, great. Well, thank you very much. Thank you to SCAD Alliance for having me today. And we forgot to mention that today is National Go Red Day, sponsored by the American Heart Association, raising awareness for women's cardiovascular disease. So we're all going red today. My job in the next few minutes is to just be enthusiastic about research and really tell you how important research has been in terms of the impact on our understanding of SCAD and also fibromuscular dysplasia, which many patients, as you know, with SCAD also have. So I'm going to briefly speak to the US Registry for FMD, talk a little bit about how research has been so important in understanding the link between FMD and SCAD, and then hopefully convince you, if you need convincing, that clinical research has had a, I think, revolutionary impact on what we know about FMD and SCAD, but you can insert your own adjective there. So first of all, I'm going to talk about the US Registry for FMD, which is sponsored by the FMD Society of America. And there's many similarities with the US FMD Registry and iSCAD. We also have a coordinating center, which is at the University of Michigan. We have a governance structure that includes a steering committee and a publications committee. Dr. Jeff Olin of Mount Sinai chairs our steering committee. We started a little bit longer ago. We started in January of 2009 at 7 clinical centers, and we currently have 17 active centers in the United States, many of which are also centers, not surprisingly, for iSCAD. Similar to iSCAD, the registry is reviewed by either the ethics committee or IRB at each site to assure patient safety during the study. And some clinical centers I know for iSCAD, everyone is given an informed consent process and signs a document. And for the US FMD registry, most centers, not all, require informed consent. We also enroll children at some of our sites. But I want to just give a brief mention to this wonderful organization. Pam Mace may be out in the social media sphere somewhere. Hi, Pam. This is the FMD Society of America, which is an organization that's here in Northeast Ohio. Pamela Mace, who is a patient with FMD, is our executive director. And similar to SCAD Alliance, the organization focuses on awareness, education, and patient and healthcare provider research with regard to FMD. We really enjoy collaborating with SCAD Alliance, and the FMDSA funds the US Registry for FMD. And we have an annual meeting in Cleveland, Ohio, and we're pleased to say we're hoping it can be live in October. For the registry, very similar to iSCAD, for the US registry, the clinicians fill out a very detailed form. This is the form we fill out for all of our patients that has all of the data fields nicely defined, as Dr. Kim went through. We're really collecting structured data, and we fill out a data form when the patients enroll in the registry, and then also at each follow-up visit. And then these data are actually transcribed into a secured online database that's maintained by our coordinating center at the University of Michigan. These are our enrolling clinical centers, and again, many overlaps with the iSCAD registry, including my own here at University Hospitals Cleveland. And we've really been working similar to iSCAD on our geographical diversity and also our racial and ethnic diversity over the past few years. So we've added some new sites within the past 3 or 4 years, and we continue to add sites. This is our annual enrollment. We've been at it now since 2009, but you can see, similar to iSCAD, really started off a little slower and then really has gained traction with enrollment. And as of this morning, there are currently 3,072 patients enrolled in the US Registry for FMD. And very importantly, we have follow-up data available for 77% of patients enrolled for 1 year or more. And I think the US FMD registry has had a number of contributions that I'm very proud of. And I should mention Dr. Kim is also an investigator in the registry. You can see her here. I think we've advanced understanding of FMD and also awareness of FMD in the community. We've had multiple manuscripts and abstracts at national meetings. But most importantly, I think the registry has directly informed how we manage our patients. We're using knowledge from this registry to be able to educate and care for our patients. And also this registry has given us an opportunity to engage with earlier career investigators to teach them about this rare disease. And these are most of our papers we've published through the registry. Papers in the past few years have come out. We focused on headaches, which are very common among patients with FMD, and also have looked at presentation by age. Just want to change gears briefly and mention what we've learned about SCAD and FMD, because they're intertwined, as many of you know, and it's really an interesting story that's kind of happening real time in our careers. This was an early paper that I probably read in about 2007 or 2008, and I thought it was really unusual, a little strange. It was a case series that came out of Vancouver, led by Christopher Buehler. And he identified 7 patients at his hospital over 2 years who were all women in their 40s and 50s and who presented with a heart attack. And at the time of coronary angiography, had these unusual looking long lesions in the mid to distal portion of the LAD artery. That was the majority. And because the protocol at this cath lab was actually to look at the abdominal aorta and renal arteries for renal artery stenosis, which was something that was kind of in vogue in the 90s and 2000s. When they did these aortograms of the abdominal aorta, they saw that these 7 patients had renal artery FMD. And they hypothesized that there was some, could this be FMD of the coronary arteries? Well, in the end, probably this was really the first case series of SCAD among women with FMD. And this was a small case series of 7 patients, but then the torch of clinical research has been carried on by others. Dr. Bueller and one of his more junior colleagues, Jacqueline Saw, started publishing additional papers. And then I think we all know Dr. Saw, who's, I believe, involved with the SCAD Alliance. She has published extensively on SCAD and FMD. And these are papers out of the Vancouver case series. I see some folks from Vancouver are on the Zoom, but found a very high percentage of patients with SCAD in this Vancouver series had FMD, up to 86%. Dr. Saw's work in more recent series has found about 2/3 of patients with SCAD have fibromuscular dysplasia in arteries outside the heart. Another group that started early on doing clinical research describing FMD was the group at Mayo Clinic. And this was one of their early publications led by, at the time, a young physician, Dr. Marisha Tweet, as well as Sharon Hayes and Rajiv Gulati. And in their Mayo Clinic case series of SCAD, they found about half of the patients had evidence of FMD, at least in the iliac arteries. They did subsequent clinical research, and in some of their more recent series, they also are reporting about 60% of patients with SCAD have FMD outside of the heart. And that rate is actually a little bit lower for pregnancy-related SCAD and higher for non-pregnancy related SCAD. So I hope I've convinced you how clinical research has taught us so much about the link between FMD and SCAD, and I'm very excited to see what data from our registry, the iSCAD registry, will contribute to this literature. So again, I think clinical research has had a fill in the blank impact, I think revolutionary impact on what we know about FMD and SCAD. And you'll hear this daily in my clinic. My clinical nurse, Becky Young, is actually on the Zoom here. I say to patients, a lot of what I'm able to tell you today is because of patients who came to see me before you, who participated in our research studies. So thank you on behalf of the entire SCAD FMD research community, and I think patients everywhere as well. Thank you for participating in research and for paying it forward for future patients diagnosed with FMD and SCAD.
Thank you so much. I agree with you. I do think it's revolutionary, and it's really neat to see in real time these, all the advances that have been made over the past years. And not even just right now, in the past year or two, but for a while, a lot's been going on. And thank all of you for discussing this in such great detail. And as a patient, it's always a good reminder, I think, for all of us watching to go thank our doctors for all the work that y'all do. In addition to seeing us in clinic every day, filling out all these surveys, working on the research, working to advance the science behind it too. I do want to go to a couple of questions. We got several questions submitted in advance. And some of these you touched on a little bit, but I want to make sure we really hammer home. One is that I've learned a lot, and patients have learned a lot from their reading and their researching at home, and we, that's encouraged for sure. Why can't we use that to figure out SCAD? Can I bring you a pile of things that I've read and hand it, to you, Dr. Wells, and say, okay, this is what I know. And I know we've talked a little bit about this over the past hour, but maybe I'll pass that to you, Dr. Wells, since I look at you. But why can't I just do that? What?
Well, you can do that, but you can't just do that. And it goes to the point that we've addressed in the talks about why have clinical research. A lot of what we read about may or may not be an appropriate interpretation of the events. For example, someone with SCAD, I believe it was Dr. Kim who mentioned about the sleep apnea, was teasing a little bit saying, what about SCAD and sleep apnea? If you have one case, that doesn't mean that there's definitely a correlation. So, but it's important to pay attention to these and findings that we have and put this all together into one big study. Does that make sense what I'm trying to answer there? So it is important to read and to have knowledge and to keep up to date. But again, we have to have an organized approach to how we do our studies, to how we do our registries, and have consistent ways that we ask the questions and interpret the data to get some meaningful results.
That does make sense. Thank you. And I know we're approaching it from lots of different ways too. We need to learn more for everybody, these generalized things, but each of us are individuals. And, I know as patients, we work with you one-on-one to develop individualized plans as well. To being able
we
to
definitely, yeah.
Go ahead.
No, so we definitely don't want to discourage anyone from reading and doing their own research. That is incredibly important, but we also need large data sets and hopefully at some point randomized controlled trials to find out what works and what doesn't.
That's awesome. Thank you. A couple specific questions for iSCAD. So Dr. Kim, I'll direct these to you, but if anybody, Dr. Wells and Dr. Gornik, I know you are both enrolling patients as well, so feel free to jump in. So questions about how can I join iSCAD? Question number one, how can I join iSCAD if I already go to one of the hospitals who are enrolling? What would a patient need to do, if they already go to Vanderbilt, but they maybe don't see you yet?
Yeah, so the answer to that is really going to depend on the site. So while iSCAD has a protocol that all investigators must follow in terms of getting the data in, each site has some leeway as to how the study is run in their own institution. So for instance, at my institution, currently I'm the only one entering data. And so I have to see the patients in clinic. I gladly open that up to others who would want to see SCAD patients with me in my clinic. However, I do know at other sites, there are several cardiologists who are a part of the study and could easily enter patient data and consent patients to the study. So what I would encourage you to do is speak with your cardiologist, inquire about the study at the site that you're at, and ask how you can participate.
Awesome. Next part of that, how can I join iSCAD if I'm not currently seen at a participating hospital, but like I live close enough that I could get there? Maybe my care is here, but I'm not that far from you.
Yes, I think this is such a good question. And when we were developing and designing this study, we really had to find a very good balance between making it very easily accessible for everyone, but also obtaining high quality data that can only really be done when you see a patient face to face, put your stethoscope on them. And a lot of times even the medical imaging might not show FMD, but you hear something. And so we know it's there. So we had to balance those things. And so the balance we came up with is that you have to be seen at an enrolling site, but we're trying to get you an enrolling site close to you that you could be a part of that.
Awesome. Okay. So if you wanted to go see that, so if I didn't go to Vanderbilt, but I could get to you, I could call and try to schedule an appointment.
Yes, but it is a clinical appointment. Okay. So it's not going to be free of charge. It is like you're going to get a second opinion. And okay. I think there are some, benefits and some pitfalls of that too. It's expensive to travel. You have to pay another doctor copay. But on the other hand, when you see a cardiologist who sees 50 cases of SCAD a year, you are going to get some additional information or additional treatment that you may not get elsewhere, simply because not a lot of cardiologists are so familiar with the care of SCAD patients in particular yet. So you are seeking sort of expertise, and that was one of the objectives of our registry, was to help develop centers of SCAD excellence around the country so that patients don't have to travel to a different state to get an expert opinion on SCAD.
That makes a lot of sense. Thank you. I think about that as an organization too for SCAD Alliance. We don't say maintain a repository of all SCAD knowledgeable docs in the world, but I always know that our PIs, our principal investigators, our iSCAD sites clearly are, physicians who are very knowledgeable and dedicated to SCAD. So that makes a lot of sense there too. Thank you. And last part of that is if there's not an iSCAD registry site near me, I know we are, bringing on more sites, but can you talk about that?
Yes, so we do have a mechanism by which any site can apply to be a part of the iSCAD registry. We have a vetting system, and we just ask sites sort of who they are, what they do, what their interests are. Like I said, our goal is to help develop centers of excellence around the country. And so any site can apply. There is an application online, and you can go to the SCAD Alliance website to find out more if your doctor is interested in being a part of the study.
Awesome. Sounds great. So if we go to a different institution, we could propose that to our doctor.
Yes, I think if your doctor has interest in being a part of the research, certainly we'd be more than happy to talk to them.
Awesome. Thank you. I know that was lots of nuances, but I wanted to make sure I think I covered all the different options for people. Another thing, Dr. Gornik, I think you touched on this a little bit, but the benefits of joining iSCAD if you're already in another registry, do you need these registries kind of cross over, or is there any downside to doing that?
I think in rare disease research, it is not uncommon to have patients who enroll in multiple registry type research studies. So we've definitely seen that in some of the FMD research studies, for example. I know there's multiple different, as mentioned, initiatives going on with SCAD. I think each of these answers different questions. And I think in terms of registry research, I think there's no issues with participating. I think if there are any questions, always discuss that with your doctor. Can I be in multiple studies? But in general, in registry research and in iSCAD, there are no issues with participating in multiple different studies. And I think each ask and will answer slightly different questions. But I think on the analysis side, when it comes to writing the papers and analyzing things, we do recognize that there may be a small percentage of patients who have participated in multiple research studies, and that'll have to be addressed and accounted for, but no problems. I think it's great. Awesome. Sign up for all of them if you're eligible.
Awesome, that makes sense. And I think it brings home a good point about the fact that SCAD isn't super common. When it's what's happened to me, it feels common. But this is in terms of, the whole country, this is a rare disease. And so bringing together this expertise makes a lot of sense. So that is the last question I have. I wanted to open it up to the three of you if there was anything else you wanted to add or comment on.
Well, maybe I'll put Dr. Kim on the spot as our study chairman. When can people start expecting to see some data coming out from the iSCAD registry?
Oh, Dr. Gornik, it's like I planted you. I'm very happy to let you know that our publications committee had a phone call with the Perfuse team last week, and we have just received back today an overall table of what the registry looks like in terms of who's in it and what risk factors they have. And so we are actively working on getting the first paper out there, and we need your help. We need the patients to please complete your questionnaires. We don't want missing data. The sort of knife to the neck for all research is missing data. If you don't have complete data, the conclusions you come to may not be absolutely correct. And so the more data, the more complete data, the better. So to directly answer the question, I hope maybe this summer we'll have something to actually show in paper form.
Awesome, that's exciting. Any other questions, comments from the group? No. I just want to thank the three of you, for joining us, for your dedication to SCAD patients year round, but also, especially today being Go Red Day is a busy day, Heart Month is a busy month, COVID's a busy time of life. And so we really, really appreciate you all joining us to go through all this. So I'm going to wrap up. This will wrap up our discussion for today. We will be posting the link on our YouTube channel and social media pages and emailed to our listserv. Be sure to subscribe to our newsletter at scadalliance.org to be sure you don't miss that. And we will see you next month for our next Ask the Experts. Thank you.
Thank you. Bye.